Greetings, I'm Dr. Karl Nath, Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's August 2019 issue. There are 4 articles this month that have been selected as our Editor's Choice and Highlights articles. The Editor's Choice this month is an original article entitled "McArdle's Sign, a specific sign of multiple sclerosis." This article is authored by Dr. Filippo Savoldi from Mayo Clinic in Rochester, Minnesota, and the University degli Studi di Milano in Milan, Italy, and colleagues from the University of Florida in Gainesville and from Mayo Clinic in Rochester, Minnesota. Ongoing advances in biochemical and genetic tests, biomarkers, and imaging, among other approaches, have steadily improved the sensitivity and specificity in diagnosing disease. Nonetheless, the proximate and critical step in delineating an underlying disease remains the history and physical examination, the H&P. Indeed, the H&P provide the major, if not only, diagnostic approach before the burgeoning diagnostic advances in medicine during the last 100 or so years. Moreover, there is renewed emphasis on the importance of the H&P and how competency and acumen in the H&P may uncover an underlying diagnosis without the need for sophisticated testing, a consequential consideration, especially in light of the contribution of diagnostic testing to the overall healthcare costs. In the present issue of Mayo Clinic Proceedings, Savoldi et al. Demonstrate the diagnostic significance of McArdle's sign in multiple sclerosis. This sign, reversible muscular weakness induced by neck flexion, was described more than 30 years ago in patients with multiple sclerosis, but it never received the attention that it truly deserved, being cited in very few publications since its original description. Savoldi et al. Undertook a prospective study of patients with finger extension weakness, a manifestation of McArdle's sign, and how it is affected by neck flexion and extension. The underlying diagnoses included multiple sclerosis, other myelopathies, and peripheral nerve lesions. Healthy controls were also studied. Each enrolled subject was examined both clinically and by a torque measurement device by personnel blinded to the underlying diagnosis. The findings demonstrate that scoring of the severity of the McArdle sign, as assessed clinically, and quantitative evaluation of flexion-induced diminution in strength, as assessed isometrically and isoinertially, was significantly greater in patients with multiple sclerosis as compared with other myelopathies, neuropathies, and healthy controls. Additionally, the clinical assessment of McArdle's sign correlated with the quantitative assessment by the torque assessment device. The authors conclude that the presence of McArdle's sign should point to the diagnosis of multiple sclerosis, and that its quantitation by a recording device and at a certain threshold is completely specific and substantially sensitive for multiple sclerosis. The authors of this study are to be commended for discerning the significance of a largely ignored clinical symptom and sign, for determining by a prospective study its specificity and sensitivity in diagnosing multiple sclerosis, and for underscoring by this salient example of McArdle's sign the fundamental importance of the history and physical in the diagnosis of disease. The first highlight article in the August 2019 issue of Mayo Clinic Proceedings is an original article entitled "Systemic Lupus Erythematosus is Associated with Increased Prevalence of Atherosclerotic Cardiovascular Disease in Hospitalized Patients." This article is authored by Dr. Gregory Katz and colleagues from the New York University School of Medicine in New York, New York. Systemic lupus erythematosus, SLE, is a multi-system autoimmune condition that may impose acute, recurrent inflammatory flares upon a backdrop of chronic progressive injury in diverse organs and tissues. Virtually any tissue and organ can be targeted by SLE, and this includes the vasculature. Such vascular involvement may be manifested as inflammation of blood vessels leading to vasculitis, thromboembolic disease, especially when there is coexisting antiphospholipid syndrome, and reactive vasospasm leading to Raynaud's phenomenon. Less well appreciated is the increased occurrence of atherosclerotic cardiovascular disease in SLE. In the current issue of Mayo Clinic Proceedings, the study by Katz et al. Is the largest one to date that analyzes the prevalence of atherosclerotic cardiovascular disease in SLE. In this nested case-control study involving more than 250,000 hospitalized patients with SLE, the majority being women, Katz et al. Demonstrated that patients with SLE, as compared with patients without SLE, had a higher prevalence of atherosclerotic cardiovascular disease, both before and after multivariable adjustment. This increased prevalence occurred both in women and in men, and was most marked in younger patients in the age range 30 to 49 years, the mean patient age being 51 years. Patients with SLE also exhibited increased prevalence for, specifically, coronary artery disease, peripheral artery disease, and cerebrovascular disease. This occurred despite the fact that the percentages of SLE patients with diabetes, hyperlipidemia, a history of smoking, or obesity were all less. SLE patients were more likely to exhibit chronic kidney disease and hypertension, but adjustment for these risk factors did not alter the essential findings of this study. Thus, traditional risk factors for atherosclerotic cardiovascular disease may not be readily invoked as contributory mechanisms for the increased occurrence of cardiovascular disease in SLE. The increased risk for vascular disease likely reflects inflammation for the following reason. In SLE, the vascular endothelium is exposed to the smoldering inflammation and acute inflammatory flares that characterize SLE, thereby leading to endothelial activation and dysfunction, vascular oxidative stress, and the attendant activation and adherence of leukocytes and platelets. Such a pathogenetic scenario may cause atherosclerotic cardiovascular disease despite the absence of hyperglycemia, hyperlipidemia, the metabolic syndrome, and a smoking history. As cardiovascular guidelines generally do not include SLE as a disease prone to cardiovascular disease, this important study by Katz et al. Underscores the need for increased awareness of increased risk for atherosclerotic cardiovascular disease in SLE, a risk that involves both sexes and younger patients, as well as the need for avoiding and/or mitigating any cardiovascular risk factors that may also coexist. The second highlight article in the August issue of Mayo Clinic Proceedings is an original article entitled Metformin and Sulfonylurea and the Risk of Incident Dementia. This article is authored by Dr. Jeffrey Scherer from St. Louis University School of Medicine in St. Louis, Missouri, and the Harry S. Truman Veterans Administration Medical Center in Columbia, Missouri, and colleagues from other U.S. institutions. Both in the United States and worldwide, populations are aging at a remarkable rate. The older adult is at a significantly increased risk for a host of chronic diseases, prominent among which is diabetes mellitus. The development of diabetes in older age in turn predisposes the older diabetic to a number of geriatric syndromes such as frailty, falls, fractures, sarcopenia, urinary incontinence, cognitive decline, and dementia. Indeed, type 2 diabetes mellitus is a major contributor to the rapidly growing number of older adults with dementia in the United States. Dementia in diabetic adults is thought to arise from varied pathobiologic processes that include, among others, diabetes-induced inflammation and oxidative stress, the adverse effects of hyperglycemia, insulin resistance, and recurrent episodes of hypoglycemia, endothelial dysfunction of the cerebral vasculature, and diabetic cerebrovascular disease. But what about the drugs themselves that are used for glycemic control, and do they influence the risk for dementia in the older diabetic? In this regard, controversy surrounds whether such risks associate with the use of metformin, a biguanide that is a first-line agent in the treatment of type 2 diabetes. In the current issue of Mayo Clinic Proceedings and in a study population involving more than 75,000 patients, Scherer et al. Convincingly addressed this question by comparing the risk for incident dementia in Veterans Health Affairs patients who were treated with either metformin or sulfonylurea as monotherapy. The patient population did not receive any therapy for diabetes for at least 2 years preceding study entry, were without dementia at baseline, and had an average age of 61 years. The results demonstrate that following adjustments for confounding and for patients less than 75 years, treatment with metformin was associated with a lower risk for dementia as compared with sulfonylurea. Moreover, similar results were obtained when such analyses were undertaken in a patient population that differed demographically and clinically from the Veterans Health Affairs patient population, namely the Kaiser Permanente Washington Integrated Healthcare Delivery System. Given the importance of metformin in the treatment of type 2 diabetes, these results are reassuring, especially in light of the increased risk of dementia in the older diabetic adult. These findings may also serve as the basis for clinical trials. Additionally, as pointed out by Scherer et al., while the reduction in the risk of dementia associated with metformin usage was relatively moderate, drugs that were previously approved for dementia, such as donazepam, did not evince a powerful effect in clinical trials. Finally, congruent with the findings of Scherer et al., are experimental studies demonstrating that metformin can mitigate the senescence phenotype and prolong lifespan. The third highlight article in the August issue of Mayo Clinic Proceedings is an original article entitled Age-Related 2-Year Mortality After Transcatheter Aortic Valve Replacement, the Young TAVA Registry. This article is authored by Dr. Iliano Navarrese from Mater Dei Hospital and Serial Medicine Network in Bari, Italy, and the University of Alberta in Edmonton, Canada, and colleagues from several other international institutions. Aortic stenosis, the most common lesion impeding left ventricular outflow, is a relatively prevalent valvular disease that becomes increasingly so with age. The clinical features and management of aortic stenosis was recently highlighted by a review article by Nkomo and colleagues in Mayo Clinic Proceedings. When patients with aortic stenosis become symptomatic, the course of aortic stenosis abruptly changes from an indolent tempo to an accelerating one, such that the likelihood of death within a few years is high in untreated patients. Until the advent of transcatheter aortic valve replacement, TAVA, definitive therapy for symptomatic aortic stenosis resided in surgical aortic valve replacement, SAVA, as neither medical therapy nor aortic balloon valvuloplasty achieved the desired outcomes. However, for a significant number of patients with aortic stenosis, substantial comorbidities and/or their advanced age impose prohibitive risks for SAVA, thereby precluding SAVA as a therapeutic option. TAVA was a brilliant innovation that effectively addressed this unmet need in these patients. Indeed, with the continued use and ongoing refinement, the application of TAVR now extends to patients with intermediate surgical risk, and a number of clinical trials are now examining whether the use of TAVR may extend even further into younger patients or those with low surgical risk. In the present issue of Mayo Clinic Proceedings, and using the Young TAVR Registry, Navarrese et al. Addressed this issue in patients 75 years old or younger, as compared with patients in the age range 76 to 86 years and with patients older than 86 years. While there were no significant differences in the 30-day and 1-year mortality, mortality in those patients in the age range 76 to 86 years was lower than patients either in the younger group, namely less than 75 years, or in the older group, namely greater than 86 years old. Notably, in patients younger than 75 years, such comorbidities as bicuspid aortic valves, bigger left ventricles, lower ejection fraction, and chronic obstructive pulmonary disease were all more common and were implicated in their increased 2-year mortality. The importance of the study by Navarrese et al. Is that it delineates how age and coexisting conditions may determine outcomes from TAVR for the treatment of aortic stenosis. Additionally, as younger age is usually associated with better outcomes for diverse diseases and interventions, the study of Navarrese et al. Is instructive in that it shows how the potential benefits of younger age in patients undergoing TAVR may be vitiated by coexisting cardiac and pulmonary morbidities. You can access these highlights and editor's choice articles free of charge during the entire month of August. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 30 seconds video article synopses, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who've made a strong impact in their field of study. Currently, we are featuring Dr. Carlo Brugnara, Professor of Pathology from Boston's Children's Hospital and Harvard Medical School, Boston, Massachusetts, interviewed by our Associate Editor, Dr. Vincent Rajkumar. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you would see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.